So when we're set with that, we'll go back and just talk for a moment about aortic stenosis. Aortic stenosis is a big problem. 2% of individuals over 65 have clinically significant stenosis, more common in men. They can have angina-like symptoms, shortness of breath, CHF ultimately. Classically, transthoracic echo is the way this is initially diagnosed. And traditionally, the treatment has been with surgical aortic valve replacement. And that was really the only way to treat it, the only life-saving approach until relatively recently. But the world has changed, and now transcatheter aortic valve replacement or intervention, TAVR, sometimes called TAVR, is really made inroads. And I'll show you exactly the extent to which that's the case and where we have a role to play. So continuing along the lines of overview, TAVR with the transcatheter heart valve is widely used. Originally, there were the core valve Edwards and the Sapien valves, which were used. And at this point, there's a much broader approach. The original preoperative or pre-planning assessment was done with echo, but in recent years, MDCT has essentially replaced that, and I'll show you a little bit of why. Just to give you a sense of, and this is not a complete list by any stretch, the different kinds of valves that exist, they're kind of all over the place. All right, what's the background for this? Well, it started out in, now it's more than 10 years ago, with high-risk patients who were really not operative candidates. And the results for TAVR were pretty darn good. Death with 1 year was lower. And then went to high-risk surgical patients. TAVR did well enough there, down to intermediate risk. And more recently, just in the last couple of years, low-risk patients, TAVR versus SAVR or surgical AVR. And you can see that actually as TAVR has improved, the death rate in the TAVR group is actually below that in the surgical group. This may have something to do with patient selection, but nonetheless, it is better than, so in all patients, potentially, you have a possibility of doing that. And this is the so-called Partner 3 trial. A lot of these were Partner 1, 2, 3, et cetera. There are other trials as well. And it shows you, and maybe the print is a little small here, I apologize, this is their key slide, but the blue line is TAVR, and death is stroke. It's sort of all adverse events. You can see the blue line is lower than the red line. So that's TAVR, the advantages of TAVR. The one on the left is just death and stroke, also lower. So this has really made the case for TAVR being kind of a go-to procedure for many patients, not perhaps every patient. Patients with complex aortic contours TAVR may not be the best approach, but that's moving, it's moved strongly in that direction. If we look at what we're looking at from a pre-procedure approach, we're looking at several things, and a big one is going to be the aortic root complex, the annulus, looking at the annulus and the annulus versus the coronary orifice, looking at whether there's aortic valve calcification, which we'll talk about, talking about the sinuses, sinotubular junction, and then onto the ascending, descending aorta and into the abdominal aorta. And then we can just talk a little bit about incidental findings in terms of initial assessment. And then we'll go on and talk about some complications as well. So the aortic assessment is key. And one of the big problems, the biggest problem we run into, which we have a role to play in a number of ways, is paravalvular leak or PVL. So sizing is very important. Knowing what your annulus looks like is very important. And we're going to be talking a lot more about this as well down the road in terms of complications. Because if you improperly size it, you undersize it, you're a setup for paravalvular leak. It's also important to understand the annulus anatomy, the aortic annulus anatomy, which is, and this just shows you none versus trace leak versus mild to severe PVL and the implications. So you can see death is a lot greater in those who have mild to severe leak. The aortic annulus is a very complicated structure, and you can get a sense of it by looking at the illustration on the right from an article published a few years ago. And the goal really, the annulus is where those hinge points are. connecting the hinge points, that green planar structure, rounded planar structure at the bottom. But in fact, although it may depict it there as sort of a circle, it's often not a circle, it's often elliptical. And in fact, it changes during the cardiac cycle. So initially, of course, echo was the first go-to procedure, but this echo is not very good for 3D assessments, and MDCT is far superior. So it's defaulted over time to MDCT in terms of pre-procedural assessment. The protocol that we use generally, we can use prospective, but we often use retrospective through the thorax, and we will tend to do dose modulation during late diastole, because we generally are going to want to look particularly at the annulus in late systole when it is actually most rounded and large. We also don't use beta blockers. That's somewhat contraindicated in aortic stenosis or nitroglycerin. So pharmacology is kind of out. And then we can, when we get below the diaphragm, we may use either a flash mode or just a quick run through the abdominal and iliofemoral vessels. Those are a little less involved. It's a little more of a typical study down there. We also have a protocol in patients with renal insufficiency where we can use less contrast. And in some patients, we actually use direct PA. So they'll get assessed by PA catheter up in the cath lab, and we will inject through that. And we can get away with as little as 20 to 30 cc's. We can also use, by the way, somebody mentioned dual energy in the other trial. We can use that to improve the attenuation of contrast and get away with less contrast for that reason as well. So this is a direct PA catheter injection. You can actually see the PA catheter, the red arrows there in the top right. And we get quite a good study throughout the whole thing. And this is just abstract just that we presented a while ago, just showing the attenuation and noise, which were really quite satisfactory versus control in patients with direct PA catheter injection with less dose of contrast. So, of course, we're going to do certain measurements in this situation, and I'm just showing you a reformat. And part of the reason I'm showing you that is so we can define, at least in a planar way, recognizing that things are a lot more complex when it comes to it, because here I show the diagram again of the annulus in the green planar structure. But just to give you a sense of some of the basic locations, aortic annulus is the lowest one, right at the LV aortic junction, and then sinus valsalva, where the sinuses are convex, and finally the sinotubular junction, which I mentioned actually in the aortic talk as being effaced in Marfan's cases, but of course normally these are atherosclerotic patients and they don't have effacement. So you can generally easily define the sinotubular junction. Of course, the sinus valsalva will be the largest structure as a rule. And so we go ahead and we will measure this. This is just an example of the difference between, if you do a retrospective, what it looks like in 30, which is end systole, and 0%, which is end diastole. And you can see that it's more rounded and therefore more appropriately measured during end systole in that 30 to perhaps 40% of the RR interval. And you can actually see this. This is just showing it in motion, showing the extent to which this thing bounces and changes shape. So we're going to be aiming for that 30% to do our measurement. And this is just an example of a reconstruction that we did, just showing how you can see the heavily calcified aortic valve, how we've put it into the proper plane and done that measurement. We've circled, and even in the best scenarios, you can appreciate that it's not round actually, it's kind of ovoid, and so we'll get, as is shown here, long and short axis dimensions, and those are what we'll report in our output. And so here's an example of some measurements, and you can see, as I said, the annulus is not necessarily circular at all. And in fact, here we have the issue of calcification, which I'll talk about a little more. And what we generally do is split the difference. So you can see we've drawn, in this case, right through the center of it, trying to be on both sides. If the calcification, as in the left-hand slide or image, is actually within the wall, we will do it that way. And then you can see the sinuses, which we often do two, sometimes three measurements, and then the sinotubular junction. So that's the aortic root complex right there, with the annulus, of course, being the most important. And then this is a measurement of the annulus to coronary sinuses. And automated software will help you with this. So every one of the vendors has good automated software, as do some of the third parties. And then we will just certainly, after we do that, we will go ahead and adjust things a little bit. It will select things on its own for you, and then you have to do a little bit of tidying up, and then you get your, it's gotten better over the years. So this is the RCA on the left, and the left coronary on the right to the annuli in both cases. And this is just some other, this is the ascending aorta, which we always measure as well. And they will give you other measurements like an LVOT. We don't necessarily report that. So that's the left ventricular outflow tract. And so, it ends up in a table. And I've shown you on the left what the table kind of looks like. That'll go into PACS. And then the measurements as reported will go into our report, and you can see these are the ones we've picked. Those the ones I have just talked about and shown, and you can see that we also included in this case. Well, we'll always include a descending thoracic aorta, and we've also done, which we don't usually do, but I put this in because we did do it in this case. You can do an aortic valve calcium score, the significance of which is just a gestalt sense. It's not an absolute a help in a major way. But this is actually the calcium score image that we actually reconstructed or actually got the score. And then also the abdominal part of the team, we actually split our studies. So the abdominal group will do the abdominal part of it, and you can see the kinds of things that they might measure. In fact, a lot of times they don't measure anything unless there's significant stenosis. They'll just do a regular report. Aortic valve calcification is very, very important, as I mentioned. It can be assessed on, contrast and you can change all sorts of factors. But risk factors for badness, which really is paravalvular leak or regurgitation, as I've been talking about, are things like a large amount, an asymmetric distribution, and involvement of the left ventricular outflow tract. Those are risk factors for a paravalvular leak. So for instance, here's a lot of calcification, and in addition, which isn't uncommon to have, but this one is involving the LVOT. That might be a little bit of a marker for slightly greater concern. I should mention bicuspid valves. Early on, bicuspid valves were discouraged, and you can see the blue and the red lines converging, which means that over time, actually the results for TAVR and bicuspid valves are no longer inferior. They're so-called non-inferior at this point. And that's essentially what this drawing shows from a JACC interventional article of really the last probably 3 years ago. And this is just a bicuspid valve. So we will do these as well with a little more care but we do the same things. We measure them. And it's a minority of our cases as well. Another thing that's been described, we don't personally do this, but it's in the literature, is assessing the CT, the MDCT, looking for the best angle, the angulation for the angiograph. In other words, cueing in the interventional cardiologist which is the best orientation. And this is just showing using different projections to try to derive the best angle for them to use when they go in there. So that may take some time and save some time in radiation for the operator of the procedure themselves. So that's another potential advantage. And this is just, again, showing it in a little more of a 3D representation, just picking out the best one and that. So the iliofemoral vessels are, another piece of it. And you need to at least have a qualitative sense of what's going on, because in most cases, that's the direction from which the TAVR is coming. Now, there are cases where they come from the subclavian, and rarely I've seen the LV apex. That's a little more involved. But the subclavian direction or axillary, sometimes. Most often, though, it's from the legs, and they're the femorals, and therefore, the complication rates are significant, and you really want to look at those in advance. And for a larger system, it's been reported as high as, meaning a large THV, large valve, could be relatively high, smaller systems lower. I think those numbers have dropped, honestly, even for the larger system, but at least initially it was more of a complication. So you're looking at the actual measurements as I am showing here, and then you're also looking at things like kinking, which is what's being displayed by the arrow in the right-hand slide. So that would be, and you can also see not only is there kinking in that iliac vessel, but there's also a substantial amount of atherosclerotic burden. So that might be a warning sign that there's going to be potentially a problem. And obviously, these are things that not only we look at, but also the interventionalists look at as well. So they're going to look at, so we have two checks, what we see, and then in addition, what the interventionals see before they actually go in and place the device. Another thing that is, that we can assist with, if you will, is the finding of incidental abnormalities on pre-TAVR CT. And there have been another number of studies looking at this. This is from our site, just looking at pre-TAVR CT. And this was, as you can see, an incident. There's a whole slew of things. Some are cardiovascular, some are relatively minor things. But certainly things like pulmonary nodules are important. And this was an incidentally discovered lung neoplasm that they didn't know about. So we can make a difference that way as well. So CT and obviously echo wouldn't be able to tell you that. So actually very valuable. So then I'll turn to complications. And CT has a very big role to play. I've already mentioned at some length paravalvular leak, but we're going to go over that one again because it is the number one concern. And then we'll talk about some other things as well. And that'll be the rest of the talk. So perivalvular leak or perivalvular regurgitation, PVL, PVR, whatever you want to label it, is more common. It is the real bugaboo for TAVRs. And this is the one echo or ultrasonographic image I'm going to show, because I otherwise have no idea what I'm looking at. But it clearly shows that there is regurgitation in a patient who had a TAVR. And so mild PVL is relatively common and not necessarily damaging, but if it's moderate to severe, it impacts mortality. And that's the 12% that you're seeing there. And one of that's not the most, I don't believe that's the latest partner trial, but it is one of the partner trials. And it's generally due to seeding or sizing, which we talked about a little bit. I mentioned about the prognosis, and pre-procedure evaluation is predictive, and we can also see it post-procedure. So let's just talk a little bit about this very important complication and just show you that there are different sizes of devices that you can put in. And so you want to put in, not you, but the interventionalist wants to put in the right size to make sure that there isn't leak. And of course, if you size it, you can possibly rupture the annulus, which we'll talk about, I believe, in a minute as well. So this article just showed that the likelihood of, if the diameter is undersized, then you're just much more likely to get perivalvular leak. So if it was sized a little above, then there was none. And you can see if it's undersized, then you could potentially get moderate to severe. That's basically what the gist of that article is. And this is just this is a comparison between using 2D TEE and using 3D cross-sectional CT. And you can see, again, that when you use TEE to try to predict what's going to happen, you ended up with substantially more perivalvular leak after the fact than if you use CT. So again, that is why the default is to CT in pre-procedure assessment, looking towards post-procedure complications. Calcifications, I alluded to this a little bit before. So calcifications, particularly those as I'm showing you here, where you've got involvement of the LVOT, and it's even been graded, as you can see here, mild, moderate, severe, is a definite predisposition to perivalvular leak, and as well, because of lack of compliance of the annulus, annular rupture. So those are important things. So calcification, PVL, and possibly rupture. And as I said, we can also image this sometimes a little hard, but this is clearly a case where you see your TAVR and you can clearly see there's a kind of a second channel outside of the TAVR itself. And so that is an indication that you are dealing with a paravalvular leak. We're not seeing it functionally like you do on echo, but you are nonetheless, this is diagnostic. So we can not only predict it or prevent the complication potentially or mitigate it against it, we can actually visualize it directly. So that's a paravalvular leak. Now, what about rupture? You can get rupture at different locations, less common, of course, by far than paravalvular leak. It's due to oversizing potentially. I'm showing you here at the level of the intra-annular level. There's higher risk factors in women because smaller annuli and certain valves like balloon expandable valves. And we already talked about LVOT calcification. This can be a serious, if not fatal, complication. And there's a whole host of abnormalities that it can lead to that I've mentioned here. And this is an example that we had, and you can see that, I didn't arrow it, but you can see it looks abnormal a little bit on the edges in a couple places, but probably can see it well here too. So it's ruptured right here, maybe a little on the other side as well. So that's actually an annular rupture. And we've had not a huge number of these, but very few actually. Fortunately, it's an uncommon complication. So annular rupture, here's another example where there was a rupture. This is actually higher than the annulus, but you can see that there's been a rupture here as well. So the annulus to coronary height is important because of the potential for a very rare complication. I'm not aware that we've had one of these, but coronary occlusion, it's said to occur in under 1% of patients. I have not. I think that's, again, as you can see, that it's older data. We do not see it nearly that often. Again, more common in the same groups of patients and as well those who have previous bioprostheses. If you have low coronary arteries, meaning under 10 millimeters, that might be an indication. So in a shallower sinus of Valsalva, and that's what this is showing here on the left, the images. And these can be divided into acute obstruction, which can give you highly lethal, potentially lethal complications, and then chronic occlusion, which is generally a little less severe. So coronary occlusion is another thing we can see, and this is just showing relative obstruction. This isn't as bad. I think this is perhaps this cast shows it better. You can see that the TAVR is actually covering the coronary artery, and it looks like there's contrast, but it looks like there may be partial interruption of the contrast going into that 3 days later, going into that coronary artery. And then another thing that we see is device migration and embolization. And we interestingly have had a couple of these, maybe 3 even. And it is 90% of these occur within 1 hour of the procedure. It's associated with distal placement of the device in the aorta. And, it may be that the anatomy of who knows, but the anatomy of the annulus and calcification may play a role. What's often done in this case is that they will go ahead, they're not going to necessarily retrieve the initial TAVR stent that's gone more distally. They'll leave it in, and then you will get a second TAVR, actually. So you'll see 2 TAVRs, one in the wrong position, one in the right position. Now, occasionally, this might be a reason to convert to a SAVR. So we've seen that as well. But I think I have an example or two of this. So you can see here's a stent migration. The stent clearly, you can see on the CT, is not in relation to the aortic valve. It's more in the ascending aorta at this point. And you can see also on the cath, that's the same. Here's another one where you can probably appreciate 2 stents. One's in the proximal aortic arch and the other is in proper position. So the first one migrated, and then they went ahead and put in a second one. You can see it here on the volumetric and the off-axial imaging. 2 TAVRs, one in proper position, and the other, the original one, which has migrated. So that's the way a device embolization looks, and that is in fact something that we do see, a handful. A couple other things: leaflet thickening there's a big New England Journal of Medicine article some years ago. The term that's used is HALT, H-A-L-T, hypoattenuated leaflet thickening, which is sort of, somebody came up with that. Stop it, I guess. But, so it can occur at variable times. And these tend to occur more in patients who have had these TAVRs for a while. Usually it starts out asymptomatic, but over time you can get a bit of a gradient, and then even worse things, as I've listed on the bottom, things like thrombosis, embolization, and so forth. But you can see the picture on the lower one in particular is showing a nice example of HALT. And you can see the red arrow is pointing to a thickened, leaflet thrombosis in that case. All right, so basically what this has turned into is a situation where we are doing the pathway. This is a few years ago, but it remains. CT has replaced echocardiography to assess a whole host of things, including the annulus, the root, et cetera, et cetera, et cetera, as well as the abdominal aorta. So we now really, essentially, we have a monopoly on at least the pre-procedural imaging. There's actually a TAVR registry that we're putting together with the ACR that's accumulating cases. So I think there's going to be more to be said on this as we go forward. And just to give you a sense of the volumes, here's a study that predicts by the year 2025, you can just see this is going up in a major way, and really everywhere. This is going to be probably, if it isn't already, the leading approach to treating aortic valve stenosis. So the conclusions here are going to be that TAVR is increasingly being performed. The recent trials, Partner 3, shows that even in low-risk patients, it's effective. It is thought that within probably now 5 years, 80% of patients will undergo TAVR for aortic stenosis. Whether we've reached the tipping point, I don't know today, but we could have. MDCT has essentially replaced transesophageal echocardiography for pre-procedural TAVR planning, unless there's some other eventuality. We've talked about benefits, including the ability to assess all the important structures, the aortic root complex, annulus, et cetera, and also its strong value to assess complications, including the number one complication of paravalvular leak, as well as a number of others that we mentioned. And so with that, thank you.